So now this is his treatment plane right here. So we so this is his scapular plane, correct? He is horizontally adducted. He's in nice scapular plane. I like to rest my knee there so that all I have to do is turn my knee out and I get my traction. This hand stabilizes him so that I can lift up, down, whatever I want. So once I have my traction, this is his scap. That means this is his humeral head, which means this is my force, and all I'm doing is pushing in this angle to get the appropriate plane. So we give our traction, and then we push. This you have to do very careful, because if we're all sitting anteriorly already, that means we can go over the hump, the anterior glenoid, easier. So this is something you always want to be aware of. I like to feel to make sure how much space is there on the posterior aspect of the humerus, and then once I give my traction, you just feel for any motion, and that's it. Sound good? All right, lay on your back. That's an anterior glide. Inferior glide. Inferior glides are very common because we commonly have problems with elevation, right? That's elevation. Scoot all the way over to me. On my camera, if I do bad lighting, just trying to get in trouble. Okay. So, with this pinned against the body, that way this here, you want to have a light grip. If I grip here, anybody know what's underneath my hand? That's right. So, we want to make sure we're not tractioning that, because I'm going to say, how's that feel? And he's going to say, oh, it's tingly. Ooh, that's not good. So, relax. I got you. Thank you. Once again, find the top of the humeral head. Make sure you're in the right spot. Wonderful. Got my C grip. I'm in the scapular plane right here. And then with this, you can do it two different ways. You can just give your traction, and then you can push your arm forward. Fine. With this technique, I like to just lock my body in like this, and I like to just turn.
Is your hand like this?
Yep. And the pressure, you could either push your arm, that's fine, or I'm just rotating my body, so I'm looking towards them.
Sorry, is this just a C grip? The C grip that you're using?
Yeah. Yep. Grips are the same. Palm, web space. Those are your two techniques.
And do you personally like that because you feel like you can, you just have a better grip?
I feel, yes, better grip, more stable, and I feel like I could use my body rather than tiring out my arm. People who do this, they're not wrong, but you're going to tire out your biceps. The other thing is that people commonly mess up their grades, right? So I'll commonly see people be doing this. You blow right past the GH, and you get nice amount of thoracic and scapular depression. And that's what we don't want. So with here, we can isolate and control this. You can do this technique, just make sure you're in the right treatment plane, that's all.
No, yeah, this feels, I definitely get
So that just takes practice. This is going to be more stiff than when you did posterior. Just be aware of that. That's inferior, anterior.
Did that treatment plane switch at all from like a posterior glenohumeral? It's the same loose pack position.
So it's generally in this, yeah, this is still the loose pack position, so your glide is now just this way. Long axis distraction. Long axis. Distract. Oh my gosh, you gotta pay with tonic water. Interesting. That's long axis distraction. You can do short axis distraction.
And why would you do that?
General capsular mobility. So loosen up the capsule for any direction. That's non-directional specific. Mobilizations are directional specific. Short axis distraction is when you're just stabilizing. You're here on the superior aspect of the humeral head, and then you're just separating. And that's just general capsular mobility. If you have non-directional problem, you're just stiff, distraction techniques are good. They're also good to warm up the joint before you do a directional specific technique.
So for like frozen shoulder?
Frozen shoulder, I would do it as a start, yeah, and then I would work towards which direction they have a restriction in.
Some bulbs are clicking.
What's the difference between doing it the long axis way and then the
Nothing.
nothing?
If he has a wrist or elbow problem, I'm gonna wanna do short axis. That's just 2 ways of doing the same thing, that's all.
When you were doing short axis, like your C group here, are you just kind of distracting still, or are you pushing? this way?
Buttressing. So I am this way,
Uh-huh.
and my direction of force is taking this out. So this is just sort of torquing over my body, and this is what is doing the traction, is taking this and pushing it over there. And you should feel just a gapping sensation in the shoulder. Versus this is just more, this is just more broad, and you can take that through. I would be here, but you would take that through a range. So this is a nice way of capsules, okay? Now let's work on your osteokinematic motion.
Oh, and you're still giving it a distraction
Because
all
if,
along.
yes, because if we have a capsular problem, me pulling and doing this won't do anything because the capsule's restricted, so it won't go up here. But if we just have a nice, maybe we'll say positional fall, maybe some structures are restricting, then just giving it some gapping, we should be able to have free range of motion. So it's a nice way of assessing the joint too. ACSC, scoot over into the middle a little bit. There you go. We just want to be in a relaxed position. So for AC, you get on top of the, they're switching cameras. They're getting on top of the joint. You don't want to be pokey. So this is a very small joint, but you want to use the same body mechanics. Your body mechanics should not change just because you are going to a smaller joint. So you should still be on the joint. I like to place the thumb or thenar eminence.
Yeah, I can do if I just.
And then this is just resting. That's not doing anything. And then all I'm doing is using my body to push forward. And that's it. That's an inferior glide. So this is for what motion?
Depression.
Elevation of the shoulder.
Oh, because you're going.
Same thing with SC. I place with females, just watch where you put in your hands. Make sure you let them know I'm not going to choke you unless you do bad in my class. And then all you do, I like to lay down my hand to rest. I lay down my finger, and all I'm doing is putting my hypothenar over my thumb. And this hand is dead weight. And then all I'm doing is applying pressure. That's it, inferiorly. Grades stay the same. But this joint and this joint move a lot less than this joint, so just be aware of that. For retraction, same exact concept. And all it is just a posterior, there we go, posterior glide.
That's AC, you're doing AC.
That's AC, and now it is SC. You do, when we say you don't want to be too forceful on that anatomical limit, that's extremely important for the SC, because say they're unstable and you're pushing too hard, that SC can dislocate and penetrate a lung. So that's why we learn our grades. Scapulothoracic joint, lay on your left side.
Have you ever anteriorly glided for protraction?
I've never had a problem with protraction. But that's what, yes, sorry, go on your back. It's probably on your slides too, so we'll go over it. This, you do get a little pokey because you cannot not get pokey. So you have to hook under the clavicle. Good. Once you're in there and you try to get your fingers nice and soft, then you are pulling towards you. SC. You try not to get the subclavian artery. And then that's why it takes a second to get there. You don't just, and then you just pull towards you.
Stop. Great sock.
Sorry, champ.
That's for inferior, right? Not anterior, pull it up, pull it up.
Really nice. Suicide.
Oh, that is anterior? Oh, my God. So
That's
towards
perfect.
you, not
This
so much.
motion. Anterior for protraction, posterior for retraction, inferior for elevation. Left side. Good. Put this under your head like you're on the beach. There you go. Chill. Good. Bend knees. Good. Come a little closer. I won't let you fall.
Which one
Don't
are we
worry.
working on now?
Scapulothoracic.
Okay, for another.
Relax, relax. I ain't gonna drop you. Relax. Got some winging going on there, huh? Gotta get that a little bit. Doing too much front, not enough back. Okay, so with this, you want to get in a position where you have control of their arms so that they can rest. You also want to be in a position where you can control the whole scapula. So this hand is usually towards the coracoid. This hand is around the inferior border, so that way, and this is just one position, you could put this resting at his side too, so don't go by just that. So with this, we want to be able to see, can he downwardly rotate? Can he externally rotate? Can he tip? Can he tip? Can he upwardly rotate? Internal rotation is this.
Retraction.
Retraction, that.
Retraction.
So all we're saying is, one, can he do those things?
And
Is
that
it
would be
mobile?
your accessory screen. This would
Yeah,
be
even
in
though
the
it's not a joint,
accessory.
technically this is when you do it, yeah. So we check those things. So we can do it here too. So he is anteriorly tipped, because this is out compared to up here. He has a little bit of bordering here too, so he needs to probably work on his serratus. I didn't assess it yet, which is why I say probably, because this needs to externally rotate to stay flat. So this is, once again, we're just doing our patterns. Does he have the mobility, 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 mobility? Then you could do PNF patterns. Did you do PNF yesterday?
Yeah.
Diagonal.
You will, yep, so diagonals. Can he go here? Can he go here? Can he go up there? Can he depress down and out? Those are just PNF patterns, and you can work on muscle strength in this same position. Trigger point issues, wherever, you can work in this same position. If it's like a rhomboid trigger point, you could work on positional release to get them to calm down. But for now, all you care about is, does it move in the directions we want? And then when you get to PNF in Clin Ed 2, it'll be push this up and over towards me. Go ahead.
Oh, wait, do they get? I'm sorry.
So relaxed.
Go in this direction. Go ahead. Good. Now slowly let me win. So you could do concentric, eccentric, or you can do push down same way. Now take here and bring this down and back. Right here. Yep, yep, yep. Keep going, keep going. Good. Now
So
push up here.
because it's not a joint, you're not necessarily doing a grade, you're just assessing.
That's for strength. Yeah, you're not looking for grade. You're just looking for what position is the scap? Why is it in that position? Is there a hypomobility issue? Is there a muscle trigger point issue? Or do I need to further assess some muscle? With him, he moves. He's a little stiff this way,
Okay.
but he has a problem here coming up. I would be very curious with his scap about his serratus anterior and his ability to keep this flat and externally rotated, based off of what I see.
Okay.
T-spine you don't have to do for this class. All right. Want to practice those?
Yeah.
All right, one or two, right?
Absorbed everything.